Hi, so Dorothy Moore here. So I'm just going to give a quick recap on diabetes emergencies, review insulin profiles, just some possible symptoms or emergencies people may present with neurodiabetes medications, and just a quick look at diabetes and COVID-19. So just in terms of DKAs, you're all familiar with, people who present with DKA, particularly in the type 1s and maybe new diagnosis of type 1 diabetes. But I suppose more we're now seeing this occurring in patients with type 2 diabetes as well, particularly in the newer medications. And with those newer medications, in terms of DKA, you're looking at, the standard symptoms of hyperglycemia, high ketone levels, thirst, polyuria, polydipsia, abdominal pain, nausea, vomiting. And they're all triggers for people being referred directly to the hospital. With hyperosmolar hyperglycemic state, in the past it would have been known as HONC, so hyperosmolar non-ketotic state. It's just changed to reflect the fact that it is hyperglycemia, and people are hyperosmolar or very dry because of the osmotic diuresis that occurs with hyperglycemia. Generally tends to happen in older, more people with more comorbidities. And again, the signs and symptoms are for anything with hyperglycemia: polydipsia, polyuria, nausea, dry skin, confusion, and very high blood sugars, but without the ketones that you expect in ketoacidosis. And again, this is emergency like DKA, where they need to be referred to the hospital for management of their dehydration, of their electrolyte imbalances, and then in terms of the DKAs for ketone clearance and also for glucose management. The other emergency would be hypoglycemia, and many patients may call you in and around, having a hypoglycemic event, or their family may contact you. These generally happen in relation to diamicron, which is the main kind of type or trade name for glycoside, and insulin. The reasons these can happen is people are having less carbohydrate foods in relation to what they normally would have for the level of insulin or the level of glycoside that they're taking, or if they miss meals or they delay meals, or if they're exercising more than they normally would, if they're taking alcohol, or if they're having too much medication, so they're being overtreated. So recap on the signs and symptoms of hypo: tired, weak, hungry, blurred vision, headache, irritable, pale, palpitations, weakness in the back of the leg. Anything, I would say to people, anything that makes them feel unusual should be considered as a hypoglycemic event, and they should test their blood sugars. Just the next slide there, please. In terms of treating of a hypoglycemia, we would generally recommend that they would take 15 to 20 grams of carbohydrate. These are just some examples of 15 to 20 grams of fast-acting carbohydrate. The reason I put these in was just in 2018 with the sugar tax, the level of glucose in Lucozade changed, and that's the treatment that people mainly use. So you need to use 170 mils, or about half a bottle of Lucozade, to treat hypoglycemia. Other things that you can use are full sugared 7-Up or Coke. You can use 150 mils of it, and the same with orange juice. Or else what can be handy is the glucose or Lucozade tablets, and you take 3 to 5 of them. We mentioned there that hypoglycemia can occur when people are on insulin. And if we look at the next slide on insulins, they're the prandial insulins or the mealtime insulins. So the main ones that we would see in use are Novorapid or Humalog or Apidra. Can we go to the next slide, please? Are Apidra. Now, all of these drugs, and then there's a newer version called Fiasp that came on the market about 2 years ago. All of these, the first three, Humalog, Novorapid, Apidra, they all work within about 10 to 15 minutes or 20 minutes of taking the drug. So, and then the Fiasp is twice as fast, it works within 5 to 10 minutes. For all of these drugs, patients need to be eating their food or have it on the table in front of them before they take their insulin. And within 3 to 5 hours, these insulins have gone out of the patient's system. So For example, if you have your breakfast at 8 o'clock in the morning, by 1 o'clock in the day, 5 hours later, that drug should be gone and eliminated out of your system. So they're very quick, rapid acting, slow length of activity in the body, and that's why they're mealtime insulins. So in terms of hypos, people often will ring us and they'll say, I took too much of my insulin, I can't remember if I took one dose or I might have taken a second dose, and they're worried about having a hypo. In that regard, we would just tell them to continuously monitor their glucose over the next 3 to 5 hours and take extra carbohydrate to prevent them from going low. The other insulins then, the next slide please, the long-acting insulins like your Lantus and your Levemir, the newer ones are Tresiba and Toujeo. They all last for up to 24 hours, and the newer ones, Toujeo and Tresiba, last for between 36 and 42 hours. There's no increased incidence of hypoglycemia with these insulins, but they're not likely to cause rapid hypoglycemia unless the person is getting too much of the drug, and then generally we see that hypoglycemia occurring during the night or first thing in the morning is where you would see it. So these don't really cause, they are, as I said, they last for 24 hours, but they don't have an impact on hypoglycemia generally unless we're giving too much of the drug. Just the next slide please there. I think on the next slide I've put in about about mixed insulins, just to highlight that mixed insulins are, examples would be Humalog, Mix 25, 50 and 70, and Novamix 30. When we talk about those mixed insulins, it means that 30% of the drug, or the 25 or the 50 or the 75, whatever the number on it is, that percentage of the drug is fast-acting insulin, and the remainder of the drug is the same insulin, but it's got protamine added to it, and that lengthens the activity and gives in effect a basal type insulin in the drug. So for example, Novamix 30, if somebody's on 10 units of Novamix 30, 3 units of it is Nova Rapid insulin and 7 units of it is the background basal insulin with the protamine added to it. The problem with this is that people can often, they don't mix their insulin correctly before they give it, or they forget to mix it, and then you might get, if somebody's on 10 units, they could end up getting front loaded with 10 units of the Nova Rapid, and because it's rapid acting and they wouldn't normally use that dose, the risk then is hypoglycemia with that. Much with the other, when I said earlier about the Nova Rapid, if that occurs, it's gone out of the system within the 5 hours, so just to keep monitoring the glucose and to take extra carbohydrate to cover it. Next slide, please. So that's the insulins. Just with the medications, I think I was looking at some of the side effects that people might present with some of the oral agents. So metformin, on the next slide, the major side effect of metformin is GI side effects, which we're all fairly aware of. And this generally occurs when the person is first diagnosed and started on metformin, or when we're changing their dose. Generally, this is a transient thing, and we would tell people to just continue with it and bear with it, and it generally passes off over the next 2 weeks. But to remind them, to take it during their meal or after their meal to reduce the risk of this happening. A rare and serious metabolic complication that can also occur at metformin is lactic acidosis, and it tends to occur in people who've got worsening renal function, who've got cardiorespiratory illnesses, or have got sepsis. And in those that are dehydrated from maybe severe vomiting or nausea or diarrhea, it can also worsen, impact on the renal function and worsen the risk of lactic acidosis. For these, similar to any acidosis, they may start presenting with dyspnea. They might have that hair-smelling odor on their breath because their lungs are trying to excrete the ketone or the lactic acid. Abdominal pain, muscle cramps, weakness, hypothermia, and eventually coma. So if you have a patient on metformin who presents with any of these kind of symptoms, then they need referral immediately to the hospital for investigation and management of both the dehydration and their electrolyte balances. On the next slide, then, we have drugs called DPP-4, and then we have injections called GLP-1s. So the DPP-4 and GLP-1s, they act on a system called the incretin system, and that is where we take in oral carbohydrate into our gut, and the gut releases an innate hormone called GLP-1. That GLP-1 is blocked very quickly by an enzyme called DPP-4. That DPP-4 on the next slide, you can see there's 4 of them available. Januvia, Tradjenta, Onglyza and Galvus are the trade names. They're a very well tolerated drug. In a very small low frequency of individuals, there is the potential for pancreatitis in 0.3% of the population. So when people who are on these drugs, even started or who are on them for a while, they can develop pancreatitis. So if they present with persistent abdominal pain, it's worth considering that they may have pancreatitis and they would need referral for investigation. The other thing that can happen is a thing called bullous pemphigoid, which is where you get watery blisters and eruptions on the skin. And again, that can happen with the DPP-4s. With those drugs, again, that is readily treatable and they would need to be referred to hospital for review by a dermatologist for treatment with that. It's not an emergency, but it is something that they would need to be referred to a hospital for. I mentioned there that the glucagon-like peptides are incretin hormones and they're naturally occurring in the gut. Again, much like the DPP-4s, this one of the serious side effects that can happen in a very small amount of people, up to 0.4% of people, is pancreatitis. So again, with these glucagon-like peptide drugs, which are Victoza, Trulicity, Ozempic and Bydureon, patients with persistent abdominal pain, we should be considering if they have background pancreatitis, and again referring them for surgical and medical review and interventions as necessary. With these drugs, the main side effects is GI complications, and for those GI complications, people will often feel nausea. They might feel they haven't got any appetite. This is part of how the drug actually works, and generally over again the first 1 to 2 weeks we would give them a low dose to start, and then we would get them to persist with it for a couple of weeks, and they're generally transient and they pass off and they tend to settle down. So if it's nausea, vomiting, loss of appetite, loss of taste, which is a difficult one in this new COVID scenario because that's one of the symptoms as well. It is worth, if they've newly gone on to Victoza or Trulicity or Ozempic, considering pancreatitis in these patients. The next drug then is a drug called gliptins, and they're around about 6 years now. There's 3 of them around. There's Jardiance, Invokana and Farxiga, and those drugs have been, so we'll just go to the next slide there. Those drugs, what they do is they block the uptake of they block the uptake of glucose in the urine, and because you're getting and it's being excreted into the urine, they block. They block the uptake of glucose in the renal tubule, and they cause an excretion of glucose. And as a result of that excretion of glucose, you get an osmotic pull of water with them. So people on these drugs will lose about 300 mils extra fluid every day. So just the next slide there. One of the side effects that again is rare and very rare, but can be quite life-threatening, is a thing called euglycemic DKA. And back earlier when I was talking about the DKAs, these drugs are given just in type 2 diabetes mainly. And in those patients, they have this risk of having a diabetic ketoacidosis state, but their blood sugars tend to be normal. So again, if patients have started on these drugs, they happen in people who've got a low beta cell function, or they've got their diabetes for a long time, they have a history of pancreatitis, they have conditions associated with restricted food intake, they have severe dehydration, or if they have any new flu or infection, it can precipitate a euglycemic DKA. Their blood sugars are completely normal, or less than 14, I suppose, so not hyperglycemic with this episode, but they do have the DKA symptoms of nausea, vomiting, abdominal pain, anorexia, excessive thirst, difficulty breathing, poor smelling breath. So again, if they present with these things, we need to be vigilant and consider that they have a normal glycemic DKA occurring, and they need referral for investigation and management to hospital. On the next slide, then, we have a complication called Fournier's gangrene. This is where you get, it's like, can we go to the next slide, please? It is a fasciitis that generally tends to happen in can we go to the next slide? So Fournier's gangrene, it's rare and potentially life-threatening occurrence. It happens in males and females, and often can be preceded by urine infections or genital infections or perineal abscess. It does need urgent, because it's a necrotizing fasciitis in the perineum, it does need urgent antibiotic therapy and surgical intervention like you would with any other fasciitis. So the symptoms patients may present with are pain, perineal tenderness, erythema. They might have a history of, as I said, of a perineal abscess or urogenital infection. They could have swelling of the genital area or the perineal area associated with malaise and fever. So again, any of these things, and they're on this particular type of drug, we would need to refer them to the hospital for investigation urgently. And this one I put in very quickly. I wouldn't expect you to see lower limb amputations presenting over the phone, but just if people do contact you and you know, they have like a reddened foot or a break on their foot, or it looks infected or it's oozing, they may well need referral to a hospital because they may be developing an infection in their foot, which could lead to a lower limb amputation, particularly in patients who are on Invokana, which is the trade name. We have found in the studies for that people with cardiovascular disease or two cardiovascular risk factors have an increased risk of amputations of the toe and the midfoot. So again, just to consider that if people do, you know, contact you with any kind of a foot infection and they have diabetes. So just the last piece there that I'm going to quickly just flick through is about diabetes and COVID. Diabetes, we know, doesn't increase your risk of getting COVID, but it does increase your risk of developing DKA and hyperglycemic, hyperosmolar states. We know that diabetes and hyperglycemia increase the risk of severe COVID-19 and its mortality. Now, there is a key difference between people who have, you know, who get in diabetics with COVID-19, and it mainly tends to be in people with type 2 diabetes. Now, you'd expect that because 85% to 90% of people who have diabetes have type 2, so you would expect there to be more people with type 2 presenting. But there seems to be an even greater risk to people who are on the SGLT2 tablets I just mentioned, the Invokana, the Jardiance and the Farxiga, of developing DKA. And we're also seeing people presenting with hyperglycemia where they've had no history of diabetes or no history of hyperglycemia in the past. So it seems to be something that's affecting the pancreas in a new novel way. And we're also seeing that there tends to be mixed presentations of you know, how people are presenting with a mix of DKA and the hyperosmolar state. So I suppose from this point of view, you know, it's just important to have a heightened awareness of hyperglycemia in COVID-19 and just to be more vigilant around the assessment for symptoms of diabetes and hyperglycememia, and have a lower threshold for referral of these patients to hospitals if they're displaying symptoms of hyperglycemia. For people who have type 1 or type 2 diabetes and check their blood sugars regularly or their ketones, we would be suggesting that they would check them every 2 hours. But they would need to be referred to hospital. As I said, if you've got diabetes, it doesn't increase your risk of getting COVID-19, but it does increase your risk of hyperglycemia, DKAs, and hyperosmolar states. And we know that diabetes and hyperglycemia does increase the risk of severe COVID-19 and its mortality. It's associated with higher mortality. Now, the outcomes tend to be influenced by, many factors, such as their poor diabetes control, what their comorbidities are, if they've got hypertension, if they've got cardiovascular disease, if they're obese, and if they've got pro-inflammatory states also. And we're all probably aware that age has quite a positive effect on mortality and COVID-19. And in one study, there was an increased risk of, in people over 18 years, the level was 14.8%. In another study in England, or data, it showed that in males who were 80 years, over 80 years, there was a 12-fold risk of worsened outcomes in diabetes patients with COVID-19. And for males and females, they tend to have the same incidence of COVID-19. However, the mortality also seems to be higher in males, with a 2-fold risk for males over females in one study. And ethnicity also has an impact. So we know that for Black, Asian, British Asian, Hispanic, Latino, and Native Americans, that they've got a higher rate of severe disease and mortality. So again, for patients who are presenting, who are older, for males and who fall into this ethnic category, really having a lower threshold for referring to hospitals in patients who have hyperglycemia, and that's new, or symptoms of hyperglycemia that's new, or who have known diabetes and are hyperglycemic. Okay, that's me in a whistle stop.